I'm going to talk about NOACs and their use in AFib/A-flutter. I know that Mike Baea did an excellent and thorough talk on this a few years ago, and he focused on the 2014 CCS guidelines and how they were derived and what evidence they were based on. So there will be some brief overlap in the beginning of this talk with his presentation, but my main objective of presenting this topic this time around is a little different. So before moving on, I have no conflicts of interest to disclose. And so despite Mike's talk a few years ago, I noticed there was some unfamiliarity with the 2014 CCS guidelines that suggest prescribing NOACs for non-valvular AFib in eMERGE. So I want to briefly review those, but the main focus of my talk is the barriers to prescribing them in eMERGE specifically, and there are 4 barriers that I'm going to discuss. The last thing I want to present is a decision aid tool that we can use to initiate a patient-centered discussion to start NOACs in eMERGE. And so my goal today is not to convince you to always prescribe NOACs for AFib, but to challenge the perceived barriers to prescribing them and encourage everyone to at least engage in a shared decision-making discussion with the patients. And so there's a lot to get through, so I would like us to hold all questions till the end. I think we'll have lots of time to discuss things at the end. So a couple of disclaimers before moving on. When I refer to AFib in this talk, I'm implying AFib or atrial flutter, and it is of the non-valvular variety. So this talk excludes rheumatic mitral stenosis, mechanical biprosthetic heart valves, or mitral valve repairs. So anything valvular is not part of this talk. NOACs to me are no longer novel or new. So the N in the NOAC is for non-vitamin K antagonists, oral anticoagulants. You can refer to them as DOACs as well. People do in the literature as well as direct oral anticoagulants. That's totally fine. It just sounds funny when I say it, so I'll stick to NOACs. And of course, vitamin K antagonist is warfarin. So there's that. So why should we care so much about prescribing anticoagulation in eMERGE for AFib or flutter? Why does this topic warrant publication of national guidelines? Because ultimately it's about stroke prevention. Cardioembolic strokes are the most severe form of ischemic strokes and make up about 25% of all ischemic strokes. Anatomically, they usually involve a large cerebral artery, so they cover a large part of your brain. And as you can imagine, they have a greater disability and mortality associated with them than other strokes. And not surprisingly, they have a high incidence of in-hospital mortality. So not only are cardioembolic strokes fatal, but the rate of these strokes is 5 times higher in the AFib population than in the non-AFib population. And that makes AFib the most common cause of ischemic strokes. Just to give you another number, the annual risk of strokes in AFib population is about 5%, which is pretty high. And physiologically, they're prone to early and long-term recurrence of these strokes. So these fatal cardioembolic strokes started to become more easily preventable with the advent of warfarin as an oral anticoagulant way back in the 1930s. But since the early 2000s, NOACs have largely replaced warfarin as the choice of oral anticoagulants because they're equal or more effective in reducing strokes, and the intracranial hemorrhage incidence is lower than in warfarin. Now, I'll get a bit more into that, the bleeding versus stroke risk assessment and all of that a little later on. But I just wanted to make the point that NOACs have arrived, and they're here to stay. And the CCS updated their recommendations in 2014 to reflect this oral anticoagulant choice. So this was the CHAD-65 score that was published in 2014. And it applies to recent onset episodes of AFib or flutter. They're defined as first detected, recurrent paroxysmal, or recurrent persistent episodes. And so the goal of this slide is really just to remind you of what the CHAD-65 score is. And I just wanted to highlight a few points about this as well. So why the age of 65? It's part of the CHADS-BAS score as well. And the reason for this is based off a Danish national cohort study, which showed that the annual risk of stroke for those between the ages of 65 and 74 was 2.1%. That makes more sense when you compare it to the hypertension annual risk, which is 1.6%. And hypertension buys you a point on the CHAD score, but so they thought that the age of 65 to 74 should at least buy you a point as well. So your patient is over 65, or 65 at least, or their CHADS is just 1. Why is an oral anticoagulant recommended for this low, not low risk, but low score group? It's because the benefit of being on an oral anticoagulant outweighs the risk of major bleeding. So for those of you who like more numbers, if you look at the warfarin numbers, those who are 65 or over, warfarin decreases the annual risk of stroke from 2.1% to 0.7%, but increases your risk of major bleeding from 0.5 to 1. So there is a benefit there. And then lastly, why only aspirin for the coronary artery disease or vascular disease group? The CCS provides 2 reasons for this. Because in this population, aspirin reduces the risk of AFib, reduces the stroke in AFib by 20% with only a minor risk in bleeding. And the second reason is because with warfarin, you have a higher risk of bleeding, and that outweighs the benefit of stroke prevention. So aspirin is a safer choice. So that was just a brief run through some of the arguments that the CCS makes to support their recommendations. Another reminder just of the CHADS-VAS score. It was created to capture the low-risk patients better than the CHADS-2 score, and you can see that it does include the age criteria of 65 to 74, which gives you a point, but over 75 gets you 2 points on this score. So that's just for comparison's sake. And then another slide just to give you an international perspective of where the CCS guidelines lie in comparison to the American and the Europeans. So the AHA and ESC both use the CHADS-VAS scores. The ESC, which is the European Society of Cardiology, they actually use a modified version of this. So to them, they do not think that the female sex is an independent risk factor for stroke, and so they don't count it as one in the absence of other stroke risk factors. And this was based off a Swedish study that was published back in 2012. The second difference is that the Europeans and Canadians largely agree that NOACs should be used over warfarin for stroke prevention in AFib. But the Americans actually support the use of warfarin equivalent to NOACs, but they actually provide a higher level of evidence to warfarin than NOACs. And lastly, aspirin is actually not recommended at all in the European guidelines. Because to them, it has a limited efficacy and significant bleeding risk. So you could probably do a half of a grand rounds just on that. So we're not going to get into that, but this is just to show you where the Canadian guidelines lie in comparison to the big other 2. So how many of you have actually read the best practices for AFib flutter from CAPE? 2, the epidemiologist, and 3, okay. Okay. So I just wanted to highlight one of the authors there, Dr. Alan Skanes. He's a cardiologist here at Western, and he was actually one of the panel members. He was super useful in giving me some insight from the cardiology perspective regarding AFib management and oral anticoagulants. So if you haven't looked at this, I urge you to read through it. It's a very short PDF. It's a great resource for streamlining and standardizing management of AFib and flutter across the department and across Canadian emerged departments. It's also a great resource to review things and for exam purposes for those of you who are in the thick of it. So look it up. I want to briefly review the NOACs that are available in Canada before delving into the meat of the talk. So there are 4 NOACs that are approved in Canada for primary stroke prevention in AFib, as well as for thromboprophylaxis and orthopedic surgeries, and for treatment in DVTs and PEs. So how do these drugs compare to warfarin? So we know that warfarin affects 4 main targets, 4 main factors, 2, 7, 9, and 10. Rivaroxaban, apixaban, edoxaban all target factor 10. It's in the name, so it's easy to remember. And dabigatran targets thrombin, which is factor 2. You can remember that with the bi in the name for 2. overall, these drugs, these newer drugs, have pretty easy dosing, once to twice daily, whereas warfarin can be variable. They have a pretty short time to therapeutic effect. So the max for some of these NOACs is about 12 hours, which is pretty great when you compare it to warfarin, which can be days. That's why the whole bridging with heparin. The half-life of these drugs is also pretty short, to a maximum of 10 hours. Warfarin, again, days for a half-life. So this is great for those life-threatening bleeds that we worry so much about. But if the patient is non-compliant and missing frequent doses, then from the stroke prevention perspective, it can be a challenge with NOACs. Just want to highlight that dabigatran is the odd one that stands out. It's also the least protein-bound and therefore amenable to dialysis. And overall, these drugs have a pretty predictable anticoagulant effect and don't require any lab monitoring. So that makes it a little easier to prescribe. Also, overall, have very few food and drug interactions. So all these factors put together from a patient perspective make it a tad easier to prescribe them and hopefully improve compliance. In the landmark trials of the NOACs, they were all published in the New England Journal between 2009 and 2013. They were all found to be non-inferior to warfarin for the outcome of stroke prevention or systemic embolism. And none of them caused more major bleeding, and all were superior for the outcome of intracranial hemorrhage. So despite these results, there have still been some concerns regarding bleeding risks on NOACs. And so this brings us to barrier number 1 in prescribing NOACs in eMERGE. This is Edna. She's a very sweet 70-year-old lady who lives at home alone. She's presenting with new onset aflutter. She's a good historian, and she's able to tell you that she felt the onset of palpitations begin 6 hours ago. Her past medical history is significant for hypertension, and she's on Norvasc for this. You can send her for a cardioversion in eMERGE, and you successfully do so. What will be your management on discharge of this patient? You know that she fits the CHAD 65 criteria and thereby, as per the guidelines, warrants a NOAC. So who here regularly prescribes NOACs for AFib when they're indicated? I see 1, raise them high, 2, 3, okay, a very small number. Okay. So when you tell her that she warrants an oral anticoagulant, she has a million questions for you. Primarily, she wants to know the efficacy of the drug and her chance of sustaining a stroke on this despite being on it. But you're all like, you might bleed on this, lady, so let's just talk about your bleeding risk first. So you talk about bleeding risk. So we're going to start with talking about a physician's biggest fear, which is bleeding risk on NOAC, specifically intracranial hemorrhage. So some of you may have already seen or heard complications of bleeding on NOACs. But there's a myth that I want to address. When NOACs were first introduced, there was huge fear in the eMERGE community, and probably still is, that these agents could not be reversed, and this would lead to tons of patients coming in with uncontrolled bleeding. However, there have been several meta-analyses that have been done, including this one by Ruff and colleagues, which indicate that the risk of major bleeding is much lower than what was anticipated, and that the rate of intracranial hemorrhage is also lower than in warfarin. So we should still talk about it, we definitely should think about it, and we should definitely discuss with our patients about this risk. But just so we're clear, we're not talking about an epidemic of patients coming in bleeding on NOACs. We're addressing that small subset of the population when we talk about those fancy reversal options and antidotes, but that's a separate talk on its own, which I know you guys have had recently as well. But you're still not convinced. You're all like, warfarin has a reversal agent. Surely, any or all bleeds, even if there are more of them than on NOACs, can be reversed because you have a measurable endpoint for reversal. So why wouldn't you just stick with what you know? Just some food for thought. Even if one were to bleed on warfarin, there's no guarantee that they're going to survive just because we have a coagulopathy endpoint to test. This was a prospective chart review that was done using a multi-center registry of patients in Calgary, Edmonton, and Ottawa. And they were treated with Octaplex, a PCC, for warfarin-associated intracranial bleeds. They found 141 patients in whom they measured hematoma volumes on CTs as well as INRs. And their primary outcomes for this were looking at INR correction. So they were looking to achieve an INR less than 1.5 within an hour of infusing Octaplex. And their other primary outcome was in-hospital mortality, because they wanted to see if this was effective. And what they found was that Octaplex was very effective in decreasing INR in a majority of patients. However, the hematoma size on CTs continued to expand in a large number of them, despite this full reversal of coagulopathy. And so, as you can imagine, the morbidity and mortality remained high because of this. Now, you can already, I'm sure, pick out a few limitations from the brief information that I've given you about this study. It was a pretty small sample size, and it was an observational study, so they lacked standardized follow-up CT scans from this. And what that means is that the scans that were ordered, it's hard to know the exact reason. It's possible many of them were ordered because there was worsening neurological status or there was a suspect of rebleeding. So there's a bias, indication bias there for sure. Having said that, it just gives you food for thought that rapid reversal of coagulopathy doesn't necessarily mean better clinical outcomes. So just something to think about when we make the argument of cheap reversal agents or lack thereof for NOACs, and the lack of a measurable endpoint in coagulopathy for these agents. But what about the mortality from intracranial hemorrhage when we specifically compare NOACs to warfarin? So this retrospective cohort study of over 140,000 patients was done in the US across over 1,000 hospitals. And they found that, so they compared patients on oral anticoagulants versus not, as well as within the oral anticoagulants, NOACs versus warfarin. And they found that in-hospital mortality was obviously higher in those who used NOACs or used oral anticoagulants than those who didn't. But then they also compared the mortality between patients on warfarin versus NOACs. And they found that NOAC use was associated with a lower risk for in-hospital mortality than warfarin. For those of you who love numbers, the adjusted odds ratio was in favor of NOACs, especially for therapeutic and supertherapeutic INRs. And these are the results from patients who are also on concomitant antiplatelet therapy. And they compared it, I didn't include the numbers from the other table, but they compared it to those who weren't on antiplatelet therapy, and the results were consistent. So the variables here really are the NOACs and the warfarin. Again, a few limitations and pros and cons. Their methodology I thought was pretty good. I'm no epidemiologist, but they did use adjusted odds ratio, so when they listed a bunch of variables that they accounted for. And even though this wasn't a randomized control trial, the control and intervention groups had similar baseline characteristics. Some of the limitations that the study itself, the authors acknowledge, is that the doses of oral anticoagulants were not available. So they didn't know exactly how much of warfarin they were taking, or the NOACs especially, and the timing of the oral anticoagulant. So as far as the study inclusion criteria went, they included everyone who had used an oral anticoagulant in the past 7 days prior to presenting to emerge with an intracranial hemorrhage. So we only know that the results of these are in those who used it and who used this blood thinner in the past 7 days, but not the exact dose or the last time that they took it. Having said all that, there is some evidence out there to show that there is decreased intracranial hemorrhage mortality in NOAC users versus warfarin, and these are quote-unquote real-world patients. That is often an argument for the clinical trials versus these studies that come out after the trials. Okay, so perhaps you're thinking, so what if NOACs are a touch superior to warfarin when it comes to intracranial bleeds? What is the short-term stroke risk to make this whole bleeding risk discussion even relevant? What are we supposed to tell Edna about the urgency of starting her on a NOAC? So after some extensive lit search, I found a couple of studies that provide some insight into this question. The first one I want to tell you about was just published this year. This is called the KP Rhythm Study. It's a 5-year retrospective cohort study that analyzed ECG monitoring data for 14 days. And it evaluated the risk of ischemic stroke based on something called AFib, or atrial fibrillation burden, AF burden. And the AF burden, it's a simple principle. It's just the percentage of the time a patient is in AFib or flutter during a specific monitoring period, which in this case is 14 days. The significance of this study is they sought out to determine whether there's a correlation between this AF burden and the risk of ischemic stroke, specifically in those who had paroxysmal AFib or sometimes thought that they may be at a lower risk of a stroke. And they were also patients who were not coagulated, or they were not anticoagulated. So these are our people, right? Like, these are the ones we see. They come in with either new onset AFib, and they're not anticoagulated, or they come in with a recurrent episode and they're not anticoagulated. So one of the goals of the study was to help identify the need of anticoagulation in a seemingly low-risk group. So they looked at 1,965 patients with ECG monitoring data for 14 days. They split these patients into 3 groups according to what I described as the AFib burden, AF burden. So we often talk about quartiles. This is a tertile. So there's 3 groups. And the highest group, tertile 3, had the highest AF burden of all. And they found that high burden to be over 11% of the time. If you're 11% or above of the time in AFib or flutter is what they found to be in the highest tertile. And this was associated with a 3-fold increased risk for stroke. You can see that by the adjusted hazard ratios. And these were adjusted for the CHADS-VASc scores, so the stroke risk scores, as well as the Atria score, which determines the bleeding risk in warfarin specifically. So a few strengths and weaknesses of this study as well. I thought it was quite unique because it was one of the only ones that I could find that was looking at specifically paroxysmal AFib patients. A common misconception is that paroxysmal AFib has a lower risk than persistent or permanent AFib, and there is evidence out there to suggest they're equivalent in that sense. And this is just one of the studies that disproves that misconception. Also, these patients were not anticoagulated, so very applicable to our population. And it was a pretty non-invasive and cheap study to do. A couple of cons. It was underpowered to evaluate the association between this AFib burden and low CHAD score, which would have been interesting to know what the correlation was. And the continuous ECG monitoring, they only had it for 14 days. So all this to say that there is a dose-response association, not a risk association, but a dose response that fits the rationale that a greater amount of time spent in AFib, even if it's infrequent, poses a risk and warrants anticoagulation for stroke prevention. So knowing this correlation, the next question is there a transient increase in this risk of stroke after an AFib episode? So in the following week or 10 days or a month, are these patients at a higher risk? And if so, is it a matter of hours or days? So before I introduce another study, I want to talk about this one that kind of set the stage for it. It's called a trend study that was published in 2015. And they found that a day with 5.5 hours or more of AFib within a 30-day period doubled your risk of a stroke. Okay, so that's been established since 2015. And so then there was this other group of investigators that took this a step further to determine how long does this increased risk of stroke last for after sustaining an AFib or flutter episode. And so I thought this was, it was an interestingly done study, so I want to describe the methods just a little bit before we can appreciate the results. So they identified over 9,000 patients on ICDs, And all these ICDs were remotely monitored, so they had data for all of them. Of these 9,000 some patients, they identified 187 patients who sustained a stroke. And they assessed their ICD data for AFib or flutter rhythm in the 120 days preceding the stroke event. And looking at the 30 days preceding that event, they were specifically looking for periods of AFib that were 5.5 hours or more or longer on any day during that 30-day period. So just to give you a sense of what the timeline looked like, day 0 was considered a stroke event, and 30 days prior to that is what they were looking at, was their case period. And they compared that to 90 to 120 days prior to that stroke event. And that was their control period. So this, by definition, is a case crossover design. And what they're doing is they're comparing that immediate pre-event exposure to that same individual's exposure history during a separate time frame. And this eliminates the need for a separate control group. So that was the whole point of that. And what they found was that the risk of stroke was highest within 5 days of one episode of AFib, and it was still high at the 6 to 10-day interval. For those of you who love numbers, because I know everybody does, you can see the odds ratios support that. And you can also see that the risk steadily decreases with longer periods and significantly decreased at the 30 days and beyond. So a few pros and cons. This was a pretty large sample size. It was interesting with this case crossover design and lack of no need for a separate control group. A few things that their ischemic strokes were identified by hospital claims, not by clinical notes. And these were, because this was done part of a veterans healthcare system in the States, a majority of these patients were men. It was a pretty expensive ordeal given that they were using ICD data and monitoring that continuously. So despite these weaknesses and probably some others that you can think of, the point of showing this was just that this paper gives us food for thought, that an individual's stroke risk is not 0 after an AFib episode. It's actually increased up to 10 days after an AFib or flutter event of 5.5 hours or more. So what do you tell Edna? She has, given that increased risk of stroke in the short term after AFib or flutter, it appears that there may be a benefit of preventing said stroke, and it may be that benefit may outweigh the risk of an intracranial bleed with a NOAC. So you're having this discussion with her, you spent like 20 minutes talking to her because you have all the time in the world in eMERGE, and Edna tells you that, her GP isn't available for months. And so now you're freaking out all over again because she doesn't have follow-up. So that brings us to my third barrier, lack of follow-up. So how important is early follow-up in these patients? And how early is early? So I just wanted to poll the audience really quick. If Edna came in with an angina-sounding story or a TIA, how many of you would start her on aspirin in eMERGE? So a bunch. Okay, like majority. Don't lie, by the way. And how many of you would ensure early follow-up with her family doctor or neuro or cardio, depending on what her symptoms are? Would you be like, you must see your family doctor within 7 days of starting aspirin? You. What's that?
It's possible to guarantee that somebody see the family doctor.
Agreed. Okay. So would you take, so say this was neuro, would you be, or cardio, whatever, would you try very, very hard to make sure she has follow-up? Or would that be a barrier for you to not start aspirin, I guess is the question. Okay. So largely speaking, no, perhaps. John Dreyer says no, therefore no. How many of you have a risk versus benefit discussion with your patients before you start aspirin? This is like baby aspirin or whatever dose, where you sit down and you're like, your risk of bleeding on this is bad or whatever, and your benefit of preventing a repeat episode of whatever this is this, and document it. Okay, so I see one hand. Are there others? So there's one person who does that. Okay. And so what if I told you that aspirin has the same bleeding risk as apixaban? I thought I was crazy too, but I'm not. So this was a systematic review and meta-analysis that was published in August of this year. And it included 5 RCTs that compared rivaroxaban/apixaban with aspirin for all indications, not just AFib. And the review aimed to look at the association between these two drugs and aspirin for intracranial hemorrhage. And they found that for the indication of AFib, apixaban and ASA were equivalent for the risk of intracranial hemorrhage. Now, I know you're probably thinking, look at this, they only found 1 RCT and you're basing this all on 1 RCT. That's not my point. I acknowledge, and the authors also acknowledge that one of the weaknesses of this review is that there's only 1 RCT looking at apixaban versus ASA. Just to clarify, the ASA doses that were used in these papers were anything from 81 to 325, so that includes your baby aspirin. The point of all of that was just, again, food for thought. And circling back to this follow-up issue, I was trying to look for what the CCS recommends for follow-up, and they're not super clear on it. But the European guidelines recommend follow-up at 1 month after starting a NOAC, either with GP, AFib clinic, cardio, whatever, and to continue follow-up at 3-month intervals. The CCS guidelines say that they're vague. They don't specifically say anything about NOAC follow-up. They say if you start any new meds, you should ensure follow-up at 4 to 6 weeks. And a new diagnosis of AFib, you should follow up with your GP within 1 week, for what it's worth. Just to stir the pot a bit, additionally, what's the family doctor or cardiologist going to discuss or say differently or do differently than we would do in eMERGE, or we can do in eMERGE? If we're not prescribing this NOAC for not a great reason, we're basically deferring the decision to another physician for a time-sensitive and potentially debilitating adverse event that we can easily prevent. And so despite all this discussion that supports the use of NOACs in AFib, I've heard a lot about the apprehension, especially regarding medical legal implications from multiple people that I've talked to. So let's take Edna as an example. Say you start her on a NOAC, and she returns to eMERGE with an intracranial hemorrhage in the following few days after a mechanical fall. That's one scenario. The other scenario is that you don't start her on a NOAC, and she returns to eMERGE within 7 days with a significant ischemic stroke, and we know her risk is higher in the short term. And she's never discharged because these strokes are 60% of the time disabling and 20% of the time fatal. So I think the medical legal implications in a scenario like this go both ways, and it ultimately comes down to shared decision-making with your patient. So it's not about what you think they should do or we think they should do. It's about empowering them with the information so that they can participate in the decision-making process. It's not about blanketly stating that you're not comfortable or we're not comfortable starting a new drug. It's about giving them the information so that you can help them make an informed decision. And so how do we do that? How do we go about having this very important discussion in a busy eMERGE and a busy shift? So in order to answer this question, let's first look at what the evidence says about patients themselves and what they value when it comes to oral anticoagulants. So there are many studies out there. I haven't obviously listed every single one, but many of them have been done that look at patient preference in AFib, specifically for oral anticoagulants. And they found a few points that are worth highlighting. AFib patients are willing to accept a higher risk of bleeding for a significant stroke risk reduction. The other thing they found was that patients often chose profiles of NOACs over warfarin. So in these studies, they don't tell you what drug they're suggesting. They just give you a profile of a drug, which fits a drug that we know, and they ask patients to choose kind of like a survey of what they would prefer. And the third thing a lot of these studies showed was that physicians are more apprehensive of the bleeding risks than patients. So a few studies, as I said, They mostly support that patients rank drug efficacy, so stroke prevention, above all other attributes, including major bleeding risk, dosing frequency, and antidote availability. And as you saw with Edna, her first question was, how is this going to prevent us, or is this going to prevent a stroke from happening again, or happening at all? And in fact, these are the same studies that have shown that physicians fear the bleeding risk the most. And on that note, the ESC, the European guidelines, and Thrombosis Canada is very explicit in saying that a high bleeding risk in itself should not automatically result in a decision not to anticoagulate, because stroke factors often track with bleeding risk. So if the bleeding risk is high, chances are the stroke risk is also pretty high. Instead, we should focus on modifiable factors. So hypertension, NSAID use, alcohol use, and antiplatelet use. Those are all part of your HAS-BLED score as well. So, and those are all potentially modifiable factors. And they put more emphasis on that than not starting the drug at all. And so what tools or resources do we have for us to consolidate all this evidence and present it to a patient like Edna in a way that she will understand? Because that's what it ultimately comes down to. Has anybody heard of the SPARC tool? Okay. Yeah, that's because I told you about it. No, you don't count. It's not a validated tool. It's the stroke prevention and AFib risk tool. That's probably why we haven't heard about it. But it was created by a pharmacist at UBC. And I just found it was an interesting way to give patients, and even us, an objective idea of what's going on, of what their risks are, rather. So it's basically a combination of the CHADS, VASC, and HAS-BLED scores. And it's intended for use in chronic AFib, so permanent or persistent AFib, but you can extrapolate the data to whomever you meet, including the paroxysmal patients. And so I filled out this tool for our friend Edna, and she gets a point for being between 65 and 74. She gets a point for hypertension on both the scores. And the way the tool works is that it spits out the annual risk of a stroke versus major bleeding for various anticoagulants, so all the NOACs, including warfarin, as well as aspirin and aspirin plus Plavix, and if you were to not give her any therapy at all. So I just think it's an interesting way, even for us, to, if you're really worried about a patient, to take a look and see objectively what their risks may be. The second resource that I want to point out is the Thrombosis Canada app. Does anybody use this app on our, okay, yeah. Okay, so there's quite a few resources on that one, actually. It's not the most user-friendly, but it's there. There's a stroke prevention and AFib summary of recommendations, which is great to flip through if you're not sure of what your patient needs. And then the other one that I find most useful is the anticoagulant dosing part of the app. So you can enter some of the characteristics of the patient, and then it spits out which NOAC they recommend for you to prescribe and what dose as well. This is based on the kidney function and everything, so you don't really have to think a whole lot. The other thing I find very interesting and useful is that online, but as well as on the app, they have PDFs of these NOAC info sheets. So if you were to start Edna on apixaban, for example, you could just print out the apixaban info sheet, check off what doses you started her on. It goes through what to do if you missed a dose or 2 doses. It goes through what other drug or food interactions there may be with NOACs, which is not many. But it's actually a very nicely laid out patient info sheet. And the other thing that is a bit more time consuming, but if you really want to use it, it's there. It's called a NOAC Follow-up checklist. Also, I don't know if it's on the app, but it's definitely on the website. It's a bit more involved. You have to click through a bunch of stuff, but ultimately it generates a PDF with an entire summary of what you did that day for the patient, what discussion you had, what their risks are for stroke, what their risk is for bleeding, what medication, what NOAC you started her on or him on. And it puts the date on it, and you can print it off and give it to your patient for follow-up if you think, if that makes you feel better. These are a lot of random resources, not random, but a few different types to use on shift. So I found this study protocol for an RCT that is being done to assess the effect of anticoagulation choice, a conversation tool, which is something that these authors created, and now they're testing it out. But the study completion date is 2021, which is a long time away. So until then, I created this handout, which is very preliminary, and it's a very basic initial template. The idea was really so that you could use it in someone, or we could use it in someone who meets criteria for a CHAT65, and they're supposed to be on NOAC. And I put the aspirin numbers there too, just for comparison. Lots of improvements to be made, but it lists basically what arrhythmia they came in with, what you did for them, what medications they're on, contraindications to NOAC. So if you're going through this and you notice they have a contraindication, you just stop. And the most important part of this, I thought, was the personal risk evaluation. So what's your baseline risk of a stroke with this, and what's your versus a bleed on a NOAC, versus what's your baseline risk with aspirin. Yeah, so like I said, it took me forever to line up those smiley faces, so I just really had to present it today. All right, so getting to the bottom line, you all survived, you made it, oh my God. So 4 major points. NOACs are superior to warfarin for major bleeding risk and equivalent for stroke prevention. The short-term risk of stroke for AFib is high, immediately after being in AFib for merely hours. And this, in my mind, outweighs the risk of bleeding on NOACs, especially when you look at the morbidity and mortality after an ischemic stroke versus a major bleed. And as I said in the beginning of the talk, my goal is not to convince you to always prescribe NOACs for everyone who meets criteria for CHAT65. But it's really, I just wanted to provide a counter-argument for the barriers that we place for ourselves in our mind for not prescribing them. And ultimately, to drive the point home that we must engage in this conversation with our patients in eMERGE, because we have the opportunity to prevent a potentially fatal outcome in these AFib and flutter patients. So thank you very much for your undivided attention. We shall discuss.